Good afternoon. I'm LaVarne Burton, President and CEO of the American Kidney Fund, and I'm delighted to welcome you to today's briefing, Increasing Kidney Transplants in Communities of Color. We're honored to bring you a star lineup of speakers, and I know that you will be informed and I hope inspired over the next hour. Before we begin, I want to thank AstraZeneca for their sponsorship of our health equity programming. I also want to thank many other sponsors, including our champions, Amgen and GlaxoSmithKline. Here's an overview of today's program, and thank you all for joining us. The American Kidney Fund fights kidney disease on all fronts as the nation's leading kidney nonprofit, working on behalf of 37 million Americans living with kidney disease and even more who are at risk. An integral part of our mission is to fight health disparities, which have been brought into sharp focus by the COVID-19 pandemic and its disproportionate adverse impact on communities of color, as well as on people with kidney disease. Here at AKF, we are acutely aware that race and ethnicity are significant risk factors for kidney failure. Even though Black people comprise only 13% of the nation's population, they account for 35% of those who are in kidney failure. People of Hispanic origin are more than 1.5 times more likely than non-Hispanics to develop kidney failure. There are two treatments for kidney failure: dialysis on a regular basis or kidney transplant. And most patients with kidney failure would like to get a transplant, but due to the organ shortage, the vast majority of people with kidney failure will begin with dialysis. And people of color are even more challenged to find a kidney transplant. Unfortunately, the health disparities that we see in kidney disease are mirrored in the access these populations have to kidney transplants. There are nearly 108,000 Americans on the organ transplant list, with 93,000 of those, or 86%, waiting for a kidney. Each day, 17 people die waiting for a transplant. For people of color, getting a transplant is even more difficult. In 2020, 45% of all kidney transplant recipients in the US were white, 27% were Black, and 18% Hispanic. I'm proud to say that 1 in 14 people who received a kidney transplant in 2020 were able to do so because of assistance from the American Kidney Fund's health insurance premium program. And nearly 65% of the people whom AKF helped to get a transplant were from communities of color. While the disparity in access to deceased donor transplant has narrowed for the last 3 or 4 years, a large disparity in receipt of living donor kidney transplants persists still, with rates almost 60% lower among Blacks. Waiting times are also substantially longer for Black transplant recipients than for white recipients, which may partially reflect the disparity in living donor transplantation among Blacks. In 2020, about 64% of living donor transplant recipients were white. There are a number of reasons why communities of color have lower access to kidney transplant, including more limited access to kidneys, reduced access to care and comprehensive health insurance coverage, equitable education and information about kidney transplants, and a scarcity of culturally competent clinicians. Our briefing today will explore these factors as well as some possible solutions. While improving the access of minority communities to transplants will require some significant changes in our healthcare system, there are some things that we can begin to do now, such as enacting policies to encourage more organ donation in minority communities, developing education programs aimed at these populations and expanding insurance coverage. Our speakers today are Andrew Donnelly from the office of Congresswoman Lisa Blunt Rochester of Delaware, Dr. Keith Melanson, head of transplants at George Washington University Hospital, Dr. Ken Southa, pediatric nephrologist at Stanford University, kidney transplant recipient, and an AKF patient ambassador, Ms. Nicole Jefferson, kidney transplant recipient and AKF ambassador, Mr. Eric Dolby, also kidney transplant recipient and AKF ambassador. And our moderator is Dr. Frances Ashe-Goins, who is also a member of our Board of Trustees. Congresswoman Lisa Blunt Rochester was going to be with us today, but unfortunately, the Energy and Commerce Committee is in the midst of a very long markup, and she has to attend that. But we're delighted that her communications director and senior advisor, Andrew Donnelly, will be here in her stead. I want to thank Andrew and the Congresswoman for their commitment to addressing health disparities that afflict communities of color, and her recent introduction of legislation, HR 3893, the Care for All Kidneys Act, that is aimed at reducing the incidence of kidney disease in minority and underserved communities. Andrew, I'll turn it over to you.
Well, good afternoon, everyone. And let me start off by thanking you, LaVarne, for that introduction. And let me start by extending the regrets of Congresswoman Blunt Rochester for not being able to join you all this morning. As LaVarne said, she is currently in day 3 of an energy and commerce markup. She's very sorry that she couldn't be with you all, but asks that I extend my thanks for all the work that you do. It's also great to see folks from the American Kidney Foundation and staff from the Tri-Caucuses here today to discuss a disease that's impacting Americans across the nation. Right now, over 37 million Americans are living with kidney disease, many of whom don't know it because there are no symptoms in the early stages. And that's a frightening statistic. We know that there are many more Americans at risk for developing this disease, especially in communities of color. Black Americans make up 13% of our country's population, but represent 35% of Americans with kidney failure. Hispanic Americans are 1.6 times more likely than non-Hispanics to develop kidney failure. Native Americans are 1.2 times more likely than white Americans to develop kidney failure. And we know that prevention of kidney disease is the best strategy. But as these harrowing statistics suggest, far too many have already developed kidney failure. And we know that kidney transplantation is a life-saving and life-changing option that can help patients get their lives back. Currently, 447 Delawareans are awaiting a life-saving transplant, and our state is exceptionally good at helping these patients get the help they need. The nonprofit Organ Procurement Organization coordinating organ and tissue donation in Delaware has ranked #1 in the nation for the 13th year in a row. And despite the challenges of the COVID-19 pandemic over the past 15 months, they have continued their life-saving organ and tissue donation services, partnering with all of Delaware's 13 hospitals. Now, it's clear that far too many folks are impacted by kidney disease and kidney failure. And we need to better understand the social, environmental, and occupational factors that contribute to the health disparities communities of color face. And that's why Congress must come together to fund research, prevention, testing, and treatment of kidney disease. It's our duty to help those individuals and their families that are affected by it, especially in minority communities. And that's why the Congresswoman was so proud to introduce the Coordination, Accountability, Research, and Equity, or CARE, for All Kidneys Act back in June. The Care for All Kidneys Act would create a national strategy to understand the health disparities that have contributed to the disproportionate impact of kidney disease and kidney failure in communities of color. Specifically, the Care for All Kidneys Act would diversify participants in clinical trials and include minority participants, develop access to home dialysis, increase access to dialysis in underserved areas, and address lower kidney transplantation rates. It would also bring key stakeholders to the table, like the National Institutes of Health and the Centers for Disease Control and Prevention, so that we can hear from them on how to better care for folks living with kidney disease. Really, the Care for All Kidneys Act aims to do just that, comprehensively care for those individuals disproportionately impacted by kidney disease and reduce barriers among diverse communities so that all Americans have access to life-saving transplants. Kidney disease can be prevented, and it's up to all of us to put the infrastructure in place so that Americans can live without the risk for kidney disease. I want you all to know that the Congresswoman on our staff will continue to work and encourage other members to co-sponsor this important legislation, because we don't have any more time to wait. Thank you again for allowing me to speak today. And on behalf of Congresswoman Lisa Blunt Rochester, thank you for all that you do. Stay safe and be well.
Thank you so much, Andrew. And thank you for being with us today and for your comments. And thanks to the Congresswoman for her leadership in fighting for kidney patients. And now I want to introduce our moderator for the briefing today, Frances Ashe-Goins. Frances is a nurse and has a long and distinguished career in healthcare. Among her notable accomplishments is that she served as Deputy Director of the HHS Office of Women's Health. She's also, we're very happy, a member of the AKF Board of Trustees. But perhaps most importantly, Frances is a patient caregiver for kidney patients. And I'm now very happy to turn it over to Frances.
Thank you, LaVarne, very much. I, as the mother of a daughter, Cheryl, who had 2 transplants and was on dialysis for 31 years, I am pleased that you, the audience, have joined us for this critical panel discussion on this very, very important issue. Our first speaker is Dr. Keith Munlison, Director of Transplant at George Washington University Hospital in Washington, D.C. Dr. Munlison will share statistics on the ethnicity of donors and recipients, ways to increase kidney donations in communities of color, and how to improve transplant outcomes. His comments are based on his experience as a transplant surgeon and his work on ethnic disparities, access to medical care, and its effect on successful transplants. Thank you.
Thank you, Mrs. Goins. I'm very honored to be here this afternoon discussing this very, very important issue. I am a transplant surgeon, and this is the work I do every day. We have a particular problem in communities of color, and this is what I'm going to talk about in this presentation. Am I gonna have the next slide? Okay, so African-American patients have 4 to 5 times the risk of kidney disease than do white patients. Black patients are more likely to die on the transplant list. And currently, when you look at how people get transplanted, the biggest problem is with live kidney donation. We've done a pretty good job of making things equitable for deceased donor kidney transplantation. But the biggest problem currently is in live donor kidney transplantation. Next slide. Can I have the next slide? Oh, okay, perfect. So here at George Washington, we are very proud of our program because we have been very successful in getting people live donor kidney transplants of all backgrounds, all ethnic backgrounds. And the way we're able to do that is we have proactive discussions with the patients and family members, and we bring to bear a lot of technology that can allow us to do transplants in a more technically challenged group of patients, meaning that because minority patients are going to be on dialysis for a longer period of time, it's more difficult to get them transplanted. And we have to do things like what's called desensitization and things of that nature. I don't need to get into the details of that, but the point is you have to bring to fore the best technology as well as the right philosophy in order to have patients receive live donor transplants. One of the things that we've addressed head on is our own healthcare personnel biases when you start talking about who could be a good kidney donor for live donor kidney transplantation. Next slide. We spend a lot of time in the community. We work with different churches. We work with local community active programs in order to engage the patients and the community where they are. Dr. Clive Callender, who's been a great mentor of mine, who's been at Howard University for many decades, he showed us the way in how to interact with the minority community in the Washington, D.C. area. And we took from his lead this idea that we would behave in much the same way that the civil rights movement worked, by going church to church in the community and discussing how people can be good kidney donors. Next slide. So the proof is in the pudding. If you look at our numbers at George Washington, we're in the green. You see that for the ethnicity of people that receive living kidney transplants, the majority of our patients are minorities. So either Asian or Hispanic or African Americans, and that vastly outpaces the United States, where only about 11% of people that get transplanted with live donors are African Americans in the United States. We are doing a much better job of that here in the nation's capital. Next slide. And then here is the ethnicity of the actual donors. And you can see at George Washington, over 35% of our donors are minority compared to the United States, which is less than 10%. Next slide. So when you break it down by ethnicity, the living donors at George Washington, more than half of our donors are minorities. And then when you break down the minority donors, what you find is that the majority of our minority donors are African American, and this is unprecedented in the United States. Next slide. Remember, I said that this is a more challenging group of patients to transplant. It's because they build up these antibodies as they remain on dialysis a long period of time. It's very important that you bring to fore all the technology that I mentioned previously. Next slide. So what we do is we utilize certain medications. It's very important that we have Medicare and Medicaid cover these medicines, which they do. And this allows us to transplant a more challenging group of patients, of which you see with minority patients. Next slide. We also do what's called ABO incompatible transplant. You don't have to be the same blood type to receive a transplant at George Washington. And this vastly increases our numbers of minority transplants. Next slide. This all started right here in the nation's capital many, many years ago, in the beginning of the 20th century. Dr. Charles Drew at Howard University invented the procedure that we utilize that enables us to transplant these sensitized minority patients. Next slide. So what are the challenges? Well, NALDAC, which is it's a great way to have our donors receive financial support when they donate their kidneys, but that program is based on the recipient's household income. So it's 350% of the poverty guidelines. However, but it's based on recipient's income and not on donor income. And that's problematic because sometimes donors can be poor. The reason why you don't see more minority donors nationwide is because this is a significant hurdle for them to overcome. Next slide. So I do believe the last administration, the Trump executive order, and what Congress did in covering Medicare coverage for immunosuppressive drugs, both of these things are very important in causing or helping us to transplant more patients, but more needs to be done. The Living Donor Protection Act, which is currently stuck in committee, I do believe needs to be passed. I also believe that we need to base our future programs on the donor income so that poor people can have better support when they are trying to donate. And it doesn't matter who they're donating to. And I also believe that in order for us to transplant more minority patients, recipient socioeconomics need to be factored in predicting what the outcomes are going to be after transplantation. Currently, what's happening is we treat everyone the same, basically making it seem like outcomes will be the same irregardless of socioeconomics, and that's just not true. Next slide. So in summary, we believe it's important to consistently emphasize the preeminence of living donor kidney transplantation to all other forms of renal replacement therapy. You have to take on head-on myths and misinformation, and you have to address implicit bias in your staff. Next slide. I think that's it. Thank you. Thank you for having me. This is an important discussion.
Exactly, a very, very important discussion. And thank you for outlining all the ways that there are differences with ethnic disparities and our access, and the issue about personnel was really, really key. Thank you again. Our next speaker is Dr. Ken Suta, instructor of pediatric nephrology at Stanford University in Palo Alto, California. He will share his perspective on kidney disease and transplant and their impact on pediatric populations, along with his personal experience as an Asian American kidney transplant recipient. Welcome.
Thank you so much for having me and for that introduction, and to the AKF for putting on this outstanding seminar. As mentioned, I'll talk a little bit about experience as a pediatrician and as a recipient myself. Next slide. So I'm a pediatric nephrologist. What that means is that I am a pediatrician, but I take care of kids with all different kinds of kidney disease that can range from things like high blood pressure or abnormal blood or protein in the urine to being born without kidneys and needing to be on dialysis or to go into transplant. In this role, I take care of kids in the hospital and outside in clinic, but I also do some research on kidney disease as well. Next slide. One of the amazing things about transplant is that we're able to see that the amazing impacts that it can have on the quality of life for our kids with kidney disease. These two examples that I have here, they were both born with kidney disease and needed to be on dialysis at a very young age. As you can imagine, being on dialysis for many hours a day, several days a week, oftentimes every day, can be extremely stressful, and it prevents kids from doing all the things that we want them to be doing, going to school, running around, playing, because they're attached to this machine in order to survive. After getting a transplant, we see amazing improvement in their quality of life as they're able to catch up on their milestones. They can be able to run free and celebrate all kinds of milestones in their lives that they weren't able to before. And that was the case with these two kids that we see here. Next slide. Oftentimes, these children can face many different kinds of barriers. Because there are only a few centers that specialize in pediatric dialysis, families often have to travel from long distances, and that requires the families to relocate if they need to have dialysis in center at those specific centers. And that can put a lot of stress on the family. By being able to increase the access to transplants that they have, we can give them a much better quality of life. The disparities and the inequities that we see are only magnified once we include racial disparities and other kinds of inequities we know are present. I'd also like to share with you another patient story. So this is not an uncommon scenario, but this patient presented with kidney disease at the age of 10 with what's called proteinuria, or abnormal protein in the urine. They didn't respond to the normal treatments of steroid treatments that can sometimes help to treat these kinds of conditions. And they were eventually biopsied, or a small sample of their kidney was taken to make a diagnosis of what's called FSGS, or focal segmental glomerulosclerosis, which basically means that there was scarring of the kidney. The doctors weren't able to completely reverse the course of this disease, but were able to slow down the progression of the decline in kidney function up until the time this patient was in college, when it became clear that the patient would need dialysis or to receive a transplant in order to survive. It might not be a surprise after the introduction, but that patient was actually me. Here, this is me about a week before I received a transplant. I was fortunate that I was able to receive what's called a preemptive kidney transplant from a living donor, my dad, when he was at the age of 60. Next slide. And because of his gift, I was able to return back to medical school. I took all of my exams on time with the rest of my class, and went on to receive my PhD and graduated from medical school. Shortly after receiving my transplant, I was volunteering as a camp counselor at a camp for kids with kidney transplants, and even was able to do things that I never imagined before my transplant, like competing in something called the Transplant Games, which are basically like the Olympics for people with transplants. Next. And with that, I even won some medals. And went on to become a pediatrician myself, and then to specialize as a pediatric nephrologist. However, the road after a transplant isn't always a smooth one, and as I mentioned, that can be the case for many patients, and can be exacerbated even when we include all of the barriers that are faced due to health inequities and health disparities. Next slide. Transplant is a treatment and not a cure, and that was the case for me as well. By the time I was about a decade out from my transplant, because of issues related to the immunosuppression that I needed to keep my body from rejecting my transplant, I had a lot of issues with infections that might just cause mono, other infections. Transplant patients can lead to complications and sometimes even cancer. Because of that, I had to reduce my immunosuppression, which then opened the door to rejection. And eventually, as I mentioned, about a decade after my transplant, I needed to go onto dialysis. I was fortunate that I was on a kind of dialysis called peritoneal dialysis that I could do nightly, every night at home. This allowed me to continue working full time as a pediatric nephrologist. And because of that, I was able to continue seeing my patients. That was due to immense privilege on my part to be able to have the resources to be able to do that. That's definitely not the case for most patients with kidney disease and failure that require dialysis. And they oftentimes have to go to in-center dialysis for several hours, several times a week, which is extremely rough and taxing on the body. Next slide. Again, I was fortunate again this time around that even though I wasn't able to find a living donor, I received this time a deceased donor transplant just after 2 years of being on dialysis. That's extremely remarkable in that the waiting times in the area where I live in Northern California oftentimes are 6 to 8 years. About 1 in 5 of the over 100,000 people waiting for a transplant in the United States, about 1 in 5 live here in the state of California. And the waiting times here where I live are amongst the longest within the state, as I mentioned, 6 to 8 years. Of the people that are waiting for a transplant here in the county where I am currently, Santa Clara County, 1/3 are Asian and 1/3 are Hispanic. And that's not even taking into account the heterogeneity that exists within those populations. Oftentimes, the data that's collected about Asian populations is flattened to just the broad category of Asian, whereas the experiences of Asian people from different backgrounds may be extremely different in terms of their risks and their access to healthcare. The experiences of a Chinese American or a Southeast Asian American, such as myself, might be completely different. Next slide. Thankfully, as I mentioned, I was able to receive that transplant, and that allowed me to return back to work. And afterwards, I started working with the AKF to try to increase awareness about disparities and access to transplants and early testing for kidney disease. As was mentioned previously, there are many different kinds of barriers that are faced by communities of color. We oftentimes are at increased risk for many of the diseases that put us at risk for developing kidney disease, including high blood pressure and diabetes. And we know that there are disparities in terms of the number of organ donors from communities of color and the rates of transplantation in communities of color. For example, in 2019, Asian Americans made up 5.7% of the nation's population, but 8.5% of total candidates waiting for a transplant. At the same time, they comprised only 3.1% of organ donors, highlighting potential barriers that might be existing in these communities in terms of recruiting people to be organ donors. Additionally, the number of organ transplants performed on Asian Americans in 2020 was only 24.7% of the number of Asians currently waiting for a transplant, whereas the number of transplants performed for white patients was 48.8% of the number of people that were waiting. Next slide. And so with that, I'd like to thank you all for your attention and for your consideration of these topics. And of course, I'd like to thank my living donor, my dad, as well as my deceased donor.
Thank you very, very much. It's wonderful to hear your story of your disease and how you turned it around and became a healthcare provider for young children, for kids that have this disease. And your story is a great story and it's very profound. Thank you. We're now going to hear from an AKF patient ambassador, Miss Nicole Jefferson. She is a transplant recipient from Dallas, Texas. She's going to talk about her experience getting diagnosed with kidney disease, going on dialysis, getting a kidney transplant as a Black woman. Thank you, Ms. Nicole Jefferson.
Hello, and thank you for having me. My name is Nicole Jefferson, and currently I live in Dallas, Texas. First of all, I would like to thank everyone for having me. I'm truly honored to be able to speak regarding something that's truly near and dear to my heart. And that's the barriers that people in communities of color experience when going through all steps of the transplant procedures and process. I have hit milestones as well as roadblocks while going through this journey. Just to give you a little background, I started with my kidney failure in 2013. I suffered from what I thought was the flu. And finally, I went to a doctor, and the doctor completely wrote me off and said it would be okay and gave me a basic prescription. However, within a week of that doctor's visit, I went to the ER, and that's when I was told that I was in kidney failure and would have to start dialysis immediately the very next day. Needless to say, I was shocked. I didn't know what was going on. No one could tell me why my kidneys failed. And over the years, there's been a lot of speculation. I've thought of things, my doctors have thought of things. However, we cannot pinpoint exactly what caused the kidney failure. So in 2003, I started dialysis, and I chose peritoneal dialysis so that I can continue to work full-time because I was working at Wells Fargo. So I did peritoneal dialysis at night while I slept, and I was able to get up and work full-time and go to work for several years. Finally, on June 12, 2008, I received my first transplant. That transplant was considered a high-risk or suboptimal kidney. The person had high blood pressure and I believe diabetes. So I had a choice to take it or not. I was advised at that time that the transplant would only last about 4 to 6 years. It didn't take until 2016, and that's when I started feeling awkward. During that time, I was actually living in Des Moines, Iowa. And I spoke with my nephrologist and I advised him that I didn't feel good. I felt that the kidney was in failure. He continued to tell me it was not because the numbers that were showing up showed that the kidney was fine. So I asked for a biopsy. That's the only thing that I could think that would prove my point that I was indeed going through rejection again. And he refused. Finally, I said I would go somewhere else to get this biopsy done. And after 6 months, the doctor decided to do the biopsy. It was on, I remember it clearly because I was actually on my way to the Transplant Games of America in 2016 to participate with Team Iowa. And my doctor called me and he said, wow, you do know your body. You are in rejection. Your kidney has scarred. So based on the numbers that we're producing, those are numbers that are somewhat skewed, in my opinion, because that goes into other barriers that we have in communities of color in trying to get transplants, trying to be placed on the list and different things like that. So as you can tell by my story so far, things shouldn't have gone that long. I had to fight for myself so that I could eventually get this biopsy to find out that I was in failure. In communities of color, we tend to have mistrust. We have mistrust for various reasons, things in the past, Tuskegee, Henrietta Lacks, and countless other things that were experimentally done on communities of color. So oftentimes when I tell people my story, especially people who look like me, they may not necessarily believe me because they aren't aware that things can go that way. Luckily, I was able to get the help that I did need for this. In 2018, my kidney started I started really feeling sick from the failure because up until this time I hadn't been on dialysis. So with that, I decided to move back to Dallas so I could have family support and be around my family. In the meantime, while I was being listed, I decided to be listed in Des Moines, Iowa, where I was living at the time, Dallas, where I had family, Nebraska Medicine, because it's close to Des Moines, and also Houston, where I also have family. So I was listed in those 4 places, waiting on my transplant. When I moved to Dallas in 2018, based on the numbers that I had at that time, my doctor wanted me to start dialysis immediately. And I told him that I was not prepared to start dialysis mentally nor physically. And a lot of people aren't aware that you can tell your doctor you don't want to start dialysis. Sometimes, yes, you may, but I'm a person who listens to my body, and I decided not to start dialysis. In 2019, I came down with a PJP pneumonia, which is a pneumonia that people with weakened immune systems get. During that time, of course, I was instructed and almost demanded by my doctor to go on dialysis based on the numbers. It's fortunate I was able to speak with Dr. Sutha, who you just heard from, and I kind of talked things through with him while I was in the hospital battling that. So when I would go to the doctor's office after going through that ordeal for months, I understood that they were somewhat mad because I simply refused to do dialysis. So fast forward to 2020, I promised my doctor that I would start dialysis on July 1st of 2020. However, in that time, on April 23rd, I received a call from Des Moines, Iowa, saying that they may have a transplant ready and available for me. They did advise that the kidney was suboptimal. It was not, it was a high-risk kidney. And I had that before, so that wasn't a concern of mine. What was possibly a concern with me is that this particular kidney, the reason that it was a high-risk kidney is because the deceased donor had been in jail for more than 72 hours within a 12-month period. This deceased donor also had sex in exchange for money within the past 24 hours, and also had sexual intercourse with someone who was an IV drug user. So that was everything that they laid out. So after discussion with my daughter, we decided that I would go through with the transplant. So during that time, they told me I had 5 hours to get to Des Moines from Dallas. So I was able to call Angel Med Flight, and they sent an ambulance to my house. And the ambulance came, took me to a small airport here in Dallas, and flew my daughter and I out. Keep in mind, this is in the midst, at the beginning of the COVID pandemic. So we were both scared, we were terrified, we didn't know what to expect. Outside of just being nervous because of the transplant, we were also wondering about COVID restrictions and things of that nature. The transplant was successful, although there were some other issues that they told my daughter and I as I was going back to be transplanted. Again, I allowed my daughter to make the decision, and she chose to go ahead and have the transplant. And I'm glad she did, because this transplant has been wonderful to me and for me. So what I had to do during that time, because it was COVID, we had to go, my daughter had to travel back and forth from Dallas to Des Moines, because I had to stay there for a month during the times that she was able to, again, in the midst of COVID. So what resonates to me is when people hear my story, they're surprised. And they didn't know that you could tell a doctor that you weren't going to start dialysis, or that you didn't feel you needed to. They simply do everything based on what the doctor tells them. A lot of people of color don't know that they can advocate for themselves, whether it be due to fear of retribution from the doctors, or whether it be any other fear of the unknown. However, a lot of times, if we were given this information when we start dialysis on things that we can and can't do, I believe that would be less of an issue. Now, this story, although it's shocking in the people of color, I just want to let everyone know that as long as you advocate for yourself and make sure that you are healthy on other aspects, that it's just, you can be open and speak with your doctor about what's going on or what you feel. Additionally, people of color aren't aware a lot of times that you can choose a different form of dialysis, which is peritoneal dialysis, and you can do that at home instead of going to a center. Another issue that I run into is that a lot of people who look like me, people of color aren't aware that you can register for transplant in different centers. They aren't aware that you can go to these different centers and possibly receive a transplant a lot sooner. In Dallas, when I first started dialysis in 2003, I was told that the wait time would be 5 years, which is about right. I went from 2003 to 2005 on dialysis. However, during the second time when I went to register again and list in 2016, I was told it would take me 7 to 10 years to be transplanted. And that's not something I wanted to do. I didn't even want to go on dialysis. So I chose other centers to make sure I was listed. And luckily, I was able to be listed in Iowa to obtain that kidney transplant a lot sooner. They also don't know about the suboptimal kidneys, the fact that you can sign up to get a kidney transplant from a donor who may have issues or different things going on. Also, they're not explained that even if you take those kidneys, they do check them they go through a rigorous background. In addition, they do check you every 3 months for a year to make sure that you don't pick up anything that the donor may have had. So one of the things I feel that the doctors do and the nephrologists is that they provide all of this information to patients one time, and it's a big data dump, which people are shocked. They're already nervous and trying to figure out what they're going to do by being diagnosed with chronic kidney disease. And so a lot of times we're left out in the cold, and we don't know different opportunities and different things that we can do. So that's why we tend to not have as much knowledge and training on other opportunities that are available for not only transplant, but also dialysis. I just want to make sure, again, thank you guys for having me. I appreciate the opportunity to express this information, and also hopefully it encourages people of color or anyone actually to make sure that they advocate for themselves and make sure they know everything that's available to them as far as transplant is concerned. Thank you.
Thank you so very, very much. What a wonderful story. And you are such an advocate for yourself, which I think is highly, highly commendable. Thank you very much. Unfortunately, our next speaker, Mr. Eric Doby, had a family emergency and is not able to be. So I'm going to tell you a little bit about my story with my daughter, Cheryl Davis. Cheryl, at age 17, was getting ready for college and had to have a health physical. At that point, she, hold on a second. At that point, she went to the doctor and her blood pressure was extremely high. As her blood pressure was high, she didn't know what was wrong. As a nurse, I didn't know what was wrong. But 2 weeks later, we got the call that she needed to come to the emergency room immediately. The first person that we met there was Dr. Clive Callender, who was mentioned earlier in the presentation. Dr. Callender talked to us about Cheryl's condition, that she was in renal failure and she needed a kidney transplant. She went on dialysis, seized during that first dialysis she was on, and but later she got a lot better. And the next year she received her first transplant from a young child. So they gave Cheryl two little kidneys. They lasted for about 3 months, and then she had to go back on dialysis. But during that time, she did very, very well. When she went back on dialysis, it took another 2 years, and she got another transplant, and this one lasted for 9 months, which was really, really good. Since that time in 1995, Cheryl was not able to get another transplant. She was listed in 4 different centers, and she tried her very, very best to stay healthy. But she had quite a few complications. And one of those complications, they found out that she had FSGS, and they found that out much, much later, in addition with all the other complications. Getting a cadaver kidney was not possible. Getting a live kidney donor was not possible. Even I had 2 family members that wanted to give Cheryl a kidney. I was not a candidate, and neither was her brother. But throughout the time and throughout Cheryl's life, she became an advocate to let her other patients, the people that were in the dialysis clinic with her, know that they should get on the transplant list, because a lot of people didn't know that. And she also talked to them a lot about taking care of the kidneys while they had them. And she talked a lot about being aware of your body and being aware of symptoms, like our last speaker talked about, and have a conversation with your healthcare provider and let them know how you're feeling and how do you feel about your condition, to be a partner in your healthcare. Unfortunately, Cheryl had surgery in February and she had died after complications of that surgery. But I'm her mom and I'm still here working with the American Kidney Fund. And I'm very, very happy to be on their board and very, very happy to be a part of this presentation today, even if I'm filling in for a wonderful advocate. Now, I would like to ensure that all of you would see the mobile advocacy network. The slide deck, could you show that, please? Thank you. We would like for you to take out your cell phones and text the word kidney to 52886 to join AKF's advocacy network. I'll say that again. Take out your cell phones. Text the word kidney to 52886 to join AKF's advocacy network. Now I will ask some questions that we've gotten. For Dr. Suter, why are wait times so long in California?
There's a variety of different reasons. So even though we do have very high rates of people signing up to be organ donors, there are just a lot of people that have underlying conditions that that predispose them to needing different kinds of transplant, whether it be a kidney or a liver or a heart. And it just based on the population and the number of people that are able to be donors, there's just an excess of people that are needing them. And so being able to come up with better strategies for encouraging people to be living organ donors and to reduce barriers that they may face, similar to what Dr. Molenson had mentioned, like the programs through NALDAC and trying to change some things around resources that are available to support people that want to be living donors are very important strategies to try to reduce that wait time.
I will ask a question. Are there regional differences throughout the country?
Yes, definitely. There are even sometimes even within the same state, there can be vast differences in what the waiting time is. And so similar to what Nicole mentioned, sometimes being aware of what the waiting times are like where you live versus maybe just like the next a region next to yours and how they might be different is really important and valuable information for people that are waiting for transplants. There are actually websites that help patients to be able to navigate that and to have a better understanding of what the resources are, and so that they can make the best decision for themselves of what center and what region is best for them. But again, there is a tremendous amount of privilege that's associated with that. Not everybody has the means to be able to get up and move at a moment's notice when an organ is available in a region where they may not necessarily live.
Thank you. For all panelists, isn't it expensive to donate a kidney? Do expenses get reimbursed? This is for all panelists.
I'll take a stab at that because that was a bit of what I mentioned in my presentation. And the answer is that it can be pretty pricey to be a kidney donor. First of all, most donors need to be off of work for at least a month. Now, if you are a white collar worker and you don't have to lift more than 10 pounds, it's possible that you could get back to work a little earlier, but that's a significant cost to not be able to work for 1 or 2 months just to be able to donate a kidney. The other issue is travel, childcare, daily living, because people that go through a major operation, they're not going to feel like cooking and cleaning and things of that nature for probably a couple of weeks after major surgery. Although the donor operation is done what we call laparoscopically with the small incisions, it's still major surgery. So yes, the costs can be prohibitive for some people. There is financial assistance out there, but as I mentioned earlier, it's really tied into the level of income of the recipient. And that's why I think we need to change these things up a little bit. My idea, or at least my concept of why the compensation of the donors was tied to the salary or the income of the recipient was because early on, the thought was that the recipient would help any prospective donors. But this is really an outmoded concept. So yes, the money can be, or funds can be found for donors, and our social workers do a lot to try to help our donors as best as we can legally help them. But it's something that needs to be addressed. That's why the majority of donors in this country are coming from lower middle class up, and people that are below the lower middle class level of income find it very difficult to be live donors.
Thank you. Any other responses?
One barrier we definitely see in pediatrics is that if a parent is donating, that puts a lot of undue financial stress on the family as well. If they have any kind of complication and aren't able to continue working for some period of time, or they're out of work for longer than they expected, those costs are not necessarily covered, and that can be a source of difficulty for many people.
Thank you. I have a question for Nicole. You got less than ideal kidney. What can you tell other patients about your decision to do this? This could expand the number of available kidneys.
Sure. The reason that I chose the high risk kidneys is because, in my opinion, and for me, it worked better than being on dialysis. I'm still in somewhat the prime of my life and wanting to, during the younger years, I had a daughter who I had to raise and get through college. Now that she's through that, there are things that I want to do, and dialysis does not provide that opportunity to be able to make these experiences and share these memories with her. So the biggest reason that I chose is just to avoid dialysis and spend that time with my family.
Okay, thank you. Dr. Sufa and Dr. Malansan, what are some of the concerns you hear from people in your community about choosing to be an organ or tissue donor? Are there any particular myths or misrepresentations that you encounter?
Well, the most common myth that continues to be problematic for deceased donors, it's not just in the African American community, but I do hear it a lot in the African American community, is that if you get injured and you're brought to the hospital, that the doctors will not work diligently to save your life so that they can take your organs for donation. And this is simply just not true. This is not true at all. For matter of fact, the opposite is actually true. There are heroic measures that are employed now to extend the life of patients that in the past we would not have employed these measures, simply because the doctors want to give the patient's family an opportunity to once again meet with the patient, but also the opportunity to donate. So if the person has a horrendous injury and the chance of survival is very low, the trauma center will do everything they can to keep the person alive so that the family at least has the opportunity to think about organ donation. On the live donor side, I think that most of the problems come from people thinking that they could be impotent if they're men, or not have children if they are women. I've heard things like you have to be the same ethnicity, or even the exact same blood type. All of these things just speak to not having enough knowledge, which is why that was a big part of my presentation. People really need to hear the truth about who can be donors and how and why they should be donors. What I would want to get out to the community is that the most important thing in order to find a donor and to be a donor yourself is to want it. If you want it, then you're going to avail yourself to the information. And once the information is disseminated, then that's the first step to making all this happen.
Thank you. Nicole.
Yes.
What can people do on an individual level to increase transplants in communities of color?
One of the things we want to do is make sure that we get rid of the myths. We explain that those are inaccurate and also give examples. Another thing we want to do is make sure that we are actively looking and we stress the importance of transplant. Some people, I understand, just simply choose to not do transplant. However, we have to find out the reason they don't want to do transplant. And most of the time, that's misinformation that they've received from some doctor, unfortunately, that's keeping them on dialysis. So another thing is ask questions, ask questions, ask questions. Communicate, reach out to people who you know who had transplants, find out what they did, find out how they can help you, and also go to the American Kidney Fund website, find out different stories. There are different resources there that can help you. But the biggest thing is get it out there that you do need a transplant, and also make sure that you're checking your resources and utilizing those resources that you have, whether they be online, whether they be in person or anything.
Thank you very much. We've reached the end of our session, and I want to thank all of our amazing speakers and turn it over to LaVarne.
Thank you so much, Frances, and thanks to all of our truly amazing and so well-informed and passionate speakers. We appreciate your participation this afternoon, and thank you so much to our audience. You can come to our website, kidneyactionweek.org, and get lots more information. I also want to thank our sponsors again, AstraZeneca, our title sponsor for all of AKF's health equity programming, as well as all the sponsors that you see here on the slide. And particularly, I want to point out our champion level sponsors, Amgen and GlaxoSmithKline. Please join us for the rest of the week of activities that are so importantly a part of Kidney Action Week, and learn everything that you can, not only to understand how your kidneys function, but very importantly, what you can do to take care of them. AKF will continue to fight to increase transplantation in communities of color, and we'll be doing that both at the federal and the state level. And we ask for your continued support in our efforts. Thank you so much.